بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على رسول الله سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, this is the third lecture in the collection which is titled as radiology, diagnostic radiology in English, or referred to by the letters DRE. And in the first lecture we dealt with the normal brain anatomy and the techniques of examination. Then in the second one we explained some facts about the cerebrovascular lesions, and we concentrated on the hemorrhage and infarction by CT and the MRI. Now we'll discuss the issue of brain tumors, and you know that this issue is very big and it contains a lot of names, a lot of diseases, and we'll try as much as we can to divide the brain tumors into categories so that we can deal with each category in a simple way. And these categories will include the supratentorial tumors, the intraventricular tumors, the infratentorial tumors, the pineal body tumors, the suprasellar tumors, and the pediatric or the congenital brain tumors. Actually, we'll not discuss all these issues in this lecture, and we'll handle only one of these issues, which is the supratentorial tumors. Then in the separate lectures we'll expose some of the remaining brain tumors. Then at first we should know that in order to diagnose the brain tumor by CT or MRI, and we should have to inject the patient with contrast media. And if we injected the patient with contrast media, we have one of two situations. Either the lesion is not enhancing at all, and this is one category of the lesions, or the lesion will take contrast media. As you can see, this is, for example, a cyst inside the brain, not taking any pattern of contrast material, and this is an enhancing tumor showing heterogeneous enhancement. Part of the lesion is enhancing, another part of the lesion is not enhancing. Then if the lesion is enhanced with contrast media, and you have one of four situations. Number one, the tumor has taken contrast media, what we call homogeneous enhancement, or the tumor has enhanced partly, part of the lesion is enhancing, part is not enhancing, and this what we call heterogeneous enhancement. Or the margin only of the lesion is taking contrast media, then we call this ring enhancement or marginal enhancement. Or you can see at the site of the lesion multiple tortuous serpiginous vessels or linear pattern of enhancement, what we call this the serpiginous enhancement. Then you remember the mass effect, and we have said that the forms of the mass effect include effacement of the cortical sulci. As you can see in this example, on the left side there are multiple cortical sulci well seen. On the right side you cannot see any of the cortical sulci. Then compression of the ventricle, and this example also showed that the right lateral ventricle is compressed, and not only that, it has been also shifted to the opposite side. And these are the three patterns of the mass effect. Number one, effacement of the cortical sulci, ventricular compression without displacement, and the contralateral shift of the ventricle to the opposite side. Then you remember also that there are three types of edema: the cytotoxic edema, which is the rim of hypodensity around the lesion; the vasogenic edema, which is a finger-like hypodensity surrounding the lesions, and the periventricular edema, which is due to obstruction of the CSF flow, resulting in retrograde backflow of the CSF across the ventricular wall, what we call the transependymal periventricular edema, or the transependymal retrograde CSF permeation. Then the vasogenic edema, which is the finger-like edema, are classified into three grades or categories. The grade 1, which is a zone of hypodensity in the range of 2 centimeters around the tumor edge. The grade 2, which represents a zone of hypodensity more than 2 centimeters but less than half of the cerebral hemisphere. And the grade 3 represents a hypodensity, a branching hypodensity finger-like, which is more than or affects more than half of the cerebral hemisphere where the lesion is. Then these are the grades of edema, and you know that vasogenic edema is more around the aggressive lesions, like the metastases, like the glioblastoma multiforme, as we will mention. Then if you are confronted by a case of brain tumor and you would like to write a report, and this report should include the definition of the lesion, whether it is well defined or ill-defined, the shape of the lesion, oval shape, irregular or so, the site of the lesion, as in this case it lies in the left frontoparietal area, the size of the lesion, and you measure the size of the lesion, the enhancement pattern, whether it is homogeneous, heterogeneous, ring, or serpiginous, the edema surrounding the lesion, if it is grade 1, grade 2, or grade 3, then the lesion and the edema exert a mass effect in the form of effacement of the cortical sulci, compression of the ventricle, shift of the midline structures. Then finally, you mention something about the normal findings, like if the paranasal sinuses are clear or not, if the posterior fossa is free or not. And this is the items to be included in the report. Number 1, this is a well-defined oval-shaped space-occupying lesion lying in the left frontoparietal area. The lesion measures about 4 by 3 centimeters in diameter. It shows a homogeneous pattern of contrast enhancement and is surrounded by grade 2 perifocal brain edema hypodensity. The lesion and the edema exert a mass effect in the form of effacement of the cortical sulci, and if you can see compression of the ventricle or shift of the midline structure, you mentioned that. And finally, you say that the posterior fossa structures are normal and the paranasal sinuses are clear, or if they are opacified, you should mention this one. And we started the evaluation of the brain tumors from the concept of the pattern of contrast enhancement. And if you look to the CT or MRI of a brain tumor, and concentrate first on the pattern of enhancement, whether it is homogeneous, heterogeneous, ring, or serpiginous. And we start by the lesions which will enhance homogeneously, and on top of these lesions by far is the meningioma. And the meningioma shows homogeneous enhancement, and this very characteristic point, which is the dural base. The meningioma should be based to the dura, and you know that the dura covered the surface of the brain, and this is known as the convexity meninges. Also, the dura lies in the falx cerebri. Then if the meningioma is here, it's known as falcine meningioma, or if it is arising from the tentorium, you call this tentorial meningioma. So we have many names for the meningioma based on the site of dural origin or dural attachment. And this is MRI T1 axial and the coronal post contrast, and you see the homogeneously enhanced lesion which is based to the dura on the convexity meninges. Then you call this the convexity meningioma. And before the era of CT and MRI, you used to have an angiogram which typically shows the tumor blush and the encasement of the vessels which are derived mainly from the blood supply from the dural vessels. And here are the different names of the meningioma according to the site of origin. The midline frontal meningioma usually arises from the dura on the floor of the anterior cranial fossa and is known as the olfactory groove meningioma or the subfrontal meningioma. And meningioma arising from the optic nerve is known as optic nerve or optic sheath meningioma. And you all know that the optic nerve does not give a neurofibroma. It has no neurolimbal sheath. The optic nerve gives a glioma of the optic nerve fibers and the meningioma from the meningeal covering of the optic nerve. Then the meningioma lies against the greater wing of the sphenoid is called the sphenoid wing meningioma, and some of the literature want to specify if this lesion is on the medial aspect of the greater wing of the sphenoid, in the middle or lateral aspect of the greater wing of the sphenoid. And then meningioma arising from the diaphragma celli is known as the suprasellar meningioma. From the dura against the clivus is known as the clival meningioma. From the dura lining the foramen magnum is known as the foramen magnum meningioma. In the posterior fossa, this is the posterior fossa meningioma arising from the convexity meninges or arising from the tentorium, which is known as the tentorial meningioma. Then this is a good example of subfrontal meningioma. In the pre-contrast study, and you see a relatively hyperdense midline lesion. In the post-contrast enhancement, the lesion showed homogeneous pattern of enhancement. And in order to see the site of meningeal attachment of this lesion, and it should have the coronal or the sagittal images. Then you will see that this lesion is resting on the floor of the anterior cranial fossa, where this meningioma is known as the subfrontal meningioma. Meningioma related to the tentorium, either above the tentorium or below the tentorium, is known as the tentorial meningioma. Then you know that the most important characters for meningioma are the homogeneous enhancement and the dural base. There are several non-essential findings of meningioma, like the presence of tumor calcification, which can be seen in 10 to 20% of the cases. Then this is a good support for the meningioma, which is known as bone sclerosis. And you know that the meningioma, whenever it comes with contact with one of the calvarial bones, this calvarial bone will be sclerotic, and it may show a significant increase in size. As you can see in this particular example of meningioma against the petrous apex and the calvarial bones in the temporal and occipital area. And if you look carefully here, and you can see this is a homogeneously enhanced lesion based to the meninges here and also along the tentorial leaflet, and you can see the significant bone increase in size and the density, and this is one of the supportive findings for the diagnosis of meningioma. Meningioma being a benign lesion does not contraindicate being surrounded by a significant amount of varifocal brain edema, which is seen in about 40% of the cases. And here is an example by MRI T1 weighted image, a homogeneously enhanced lesion based to the convexity meninges with sclerosis and enlargement of the calvarial bones against the base of the meningioma. Supportive diagnostic issue is the bone sclerosis. And these are different types of meningiomas. Meningioma against the greater wing of the sphenoid is known as the sphenoid wing meningioma. Meningioma in the midline frontal area is known as the subfrontal or olfactory groove meningioma, and the meningioma related to the falx cerebri is known as the falcine meningioma. In all cases, the tumor should show homogeneous contrast enhancement. By MRI, you know the appearance of the tumor will depend on the water content of the lesion, and some types of meningioma have a little interstitial water. So, and the T1 weighted image, they will appear of intermediate signal, and also in the T2 weighted image, they will show intermediate signal. But most importantly is the appearance of the lesion in the post-contrast images, where you can see a homogeneous pattern of enhancement, and the lesion is based to the convexity meninges. And this is an example of convexity meningioma by T1, T2, and T1 post-contrast. In the T1 weighted image, the tumor is of intermediate signal. In the T2 weighted image, the tumor is also of intermediate signal. And after contrast injection, and you can see homogeneous enhancement of the tumor, which is based to the convexity meninges. Then whenever the tumor comes into contact with the convexity meninges or any type of the meninges, it may show this very characteristic appearance, which is known as the dural tail. And the dural tail means that there is a thickened enhancing dura along the edges of the tumor. This is not a characteristic finding of meningioma and can be seen in other tumors, but it may occur and may not occur. And you can see here, this is a homogeneously enhanced lesion based to the dura diagnostic of convexity meningioma without the presence of dural tail. And this is a homogeneously enhanced lesion based to the dura diagnostic of meningioma with the characteristic dural tail, as you can see. Then in the meningioma, in the T1 weighted image after injection of contrast, you should see homogeneous enhancement in the dural based lesion. But you know that meningioma contains some vessels, and the vessels show low signal in T1 and T2, and they do not show contrast enhancement because of the flow. Then if you see serpiginous low signal lesions within the tumor or at the edge of the tumor, you consider these as vessels. And also the tumor may contain calcium, as we have mentioned, and you know calcium usually show low signal in the T1 and the low signal in the T2 weighted image, and the calcified area will not be stained by the contrast media. Then it is acceptable to see vessels and to see calcium, which are of low signal within the homogeneously enhanced tumor based to the dura diagnostic of meningioma. Then one of the accepted findings in meningioma also is the presence of a cystic component. And this is the meningioma in the T1 weighted image, a solid lesion with a cystic component capping the tumor edge. And this cystic component, because of the water content, it will appear black in the T1 and bright in the T2, and it will not enhance with contrast media. But the solid component representing the major part of the tumor is homogeneously enhanced based to the dura, which is in this case the falx cerebri. Then you remember, a meningioma may have a cystic component, and this cystic component is usually capping the tumor edge, and this cystic component does not usually show contrast enhancement. It may show internal septation and may show faint marginal post-contrast enhancement. And this is another example of convexity meningioma showing three major findings. Number one is the presence of cystic component, and you see this cystic component in the T1 weighted image, and this cystic component is almost not identifiable after contrast injection. Number two, the presence of bone sclerosis, and you see this part of the calvarium is dark, and this means that the presence of sclerotic reaction against the base of the meningioma, and the presence of the dural tail, and we can see enhanced thickened dura along the edges of the meningioma. Then meningioma can occur anywhere inside the cranium based to the dura, and this is one of the common lesions in the paracellular area or the cavernous sinus area. The meningioma paracellular, intermediate signal in the T1, a relative increased signal in the T2, and homogeneous post-contrast enhancement. Then meningioma in the midline frontal area is known as the subfrontal meningioma. This meningioma shows intermediate signal in the T1, intermediate signal in the T2, intermediate signal in the FLAIR image, surrounded by a mild degree or moderate degree of perifocal brain edema. The edema is of low signal in the T1, high signal in the T2, high signal in the FLAIR. But what is very important is the appearance of the tumor after injection of contrast media, and here you can see homogeneous enhancement of the tumor. Then meningioma can be multiple, can occur inside the ventricle, can occur inside the bone, intraosseous meningioma or meningioma en bloc, and you remember that meningioma occur in the optic nerve. It arises from the meningeal covering of the optic nerve. Multiple meningiomas, for the diagnosis of multiple meningiomas, each one of the lesions should fulfill the criteria of a meningioma. Like this one, and you see, this is the homogeneously enhanced lesion based to the dura. It can fit with the diagnosis of meningioma. And this is another lesion which is homogeneously enhanced based to the dura at the cerebellopontine angle, can fit with the diagnosis of meningioma. Then we are dealing with a case of multiple meningiomata. And this is also another case where you can see a meningioma against the convexity meninges and another meningioma in the paracellular area, based to the dura in the paracellular area, based to the dura in the tentorium and at the petrous apex, and against the cerebellopontine angle region. A meningioma inside the ventricle is thought to arise from enfolding of the meningeal tissue during the formation of the choroid plexus. And there is a characteristic site for this meningioma, which is the trigone of most likely the left lateral ventricle. It can occur also in the trigone of the right lateral ventricle. And you know the trigone of the ventricle is the junction between the body and the occipital horn. Meningioma can also occur inside the fourth ventricle and inside the third ventricle, but the most common site for the meningioma is the atrium or the trigone of the ventricle, especially the left one. Then you will see a meningioma without a meningeal base. Homogeneously enhanced lesion may contain calcium, but you cannot here see the base of the dural base, because this is an intraventricular location. And meningioma at this site will obstruct the flow of the CSF in the occipital horn of the ventricle. Then this horn will be dilated, and sometimes you will see retrograde transependymal CSF permeation around this dilated horn. This is a classic appearance of an intraventricular meningioma in the trigone of the left lateral ventricle, showing homogeneous contrast enhancement in this T1 weighted image. The meningioma intraventricular represents 2% of all meningiomas intracranial. 80% of these intraventricular meningiomas occur in the lateral ventricle, particularly the trigone of the left one. And this is the most common trigonal mass in adults, because if this is child, this is a good diagnosis for choroid plexus papilloma, as we mentioned after that. And calcium is present in the meningioma like any other types of meningiomas, and it shows intense enhancement in both CT and MR images. Intraosseous meningioma or meningioma en bloc will arise mainly in the lateral orbital wall and the greater wing of the sphenoid, resulting in significant increase in the size and the sclerosis of these bones. And this tumor is usually associated with an extraosseous homogeneously enhanced soft tissue component, which may extend inside the orbit and may extend outside the orbit in the temporal area. And this meningioma will significantly encroach on the orbital cavity, resulting in the major complaint of the patient, which is the proptosis. The meningioma can be totally calcified if it is a long-standing small one, and you can see a densely calcified lesion against the medial part of the greater wing of the sphenoid. I usually say that if you are confronted by a mass like this formed of bone density, it is better to diagnose this as a meningioma which has been totally calcified, and do not rush into the diagnosis of an osteoma of the calvareal bones, because meningioma here is more likely to occur from the inner table, but osteomas are usually related to the outer table of the calvareum. Then we came to an important issue, which is the hemangiopericytoma, which is also a tumor of meningeal origin. And this tumor has many diagnostic relationships to the meningioma itself. But this tumor is aggressive, and it represents about 0.4% of all intracranial tumors. You remember, meningioma is about 14%. And this tumor is usually larger than 4 centimeters in diameter, and it affects males more than females. And you know that meningioma affects females more than males. Then this is from its name, hemangiopericytoma is a markedly hypervascular lesion. It does not show calcium nor hyperostosis of the calvarium. And instead, it may erode the calvarium and extend into extracranial. And if it is removed, it has a high incidence of recurrence rate with metastasis extra CNS. Then you see this is a male patient, and this tumor is usually seen in males of middle-aged or elderly males. You see this presents with the frontal scalp swelling here, and the MRI T1 shows intermediate lesion, T2 shows intermediate lesion, and after a contrast injection it shows homogeneous enhancement. But see that this lesion is large. It's also based to the dura, it arises from the dura, and it does not induce calvarial sclerosis. Instead, it may induce calvarial erosions. And you can see another example in a male 68 years old with a tumor which is almost homogeneous enhanced when apart from these small areas of breakdown. And the tumor is based to the meninges. It has eroded and destroyed the calvarium with extracranial extension of the tumor. Then one of the diagnostic possibilities is what we call malignant meningioma, but this term is no more in the bracts, the hemangiopericytoma, the glioblastoma multiforme, the lymphoma and the metastases, and this type of the neuroblastoma. But remember, whenever you see a tumor which is similar to a meningioma but large and erodes the calvarium in a male patient, elderly male or middle-aged male, then think of this hemangiopericytoma. And this is a male 40 years old with the homogeneously enhanced lesion in the high parietal area, and you see the erosion of the calvarium, and the skull X-ray show the destruction of the calvarial bones with some component in the extracranial area. Then we came to another lesion which is relatively rare compared to the meningioma, which is the lymphoma. And lymphoma is put into this category because of its homogeneous post-contrast enhancement. This lesion is an homogeneously enhanced lesion with no dural base, and this is one of the criteria of the meningioma. Meningioma shows homogeneous enhancement but with no dural base. It occurs in the periventricular area, involves the corpus callosum, can cross the midline, as we will mention in a moment. And you remember that meningioma lymphoma has an intimate relation with the immunity status of the patient, and it is a well-known tumor in patients with AIDS, representing about 60% of the lymphoma in these types in these patients. Lymphoma in AIDS patients is usually of the high-grade non-Hodgkin type, and it may affect the leptomeninges. It may show periventricular location, and it may show particularly in immune-compromised patients some form of heterogeneous enhancement. But lymphoma in an immune-competent patient like this one will show low signal in the T1 or intermediate signal in the T1 and T2, but homogeneous post-contrast enhancement. Homogeneous post-contrast enhancement with periventricular location, intimately related to the splenium of the corpus callosum, crossing the midline, producing little mass effect compared to the tumor size. All these criteria favor the diagnosis of lymphoma. And then lymphoma is a homogeneously enhanced lesion with no dural base, periventricular location, can cross the midline if it affects any part of the corpus callosum. Little brain edema, the tumor is usually surrounded by little perifocal brain edema and exert little mass effect on the adjacent structures compared to the tumor size. Then this lesion does not show calcification. Then the lymphoma in immune compromised patient or in AIDS patient will show in sometimes heterogeneous enhancement, and it may show the significant perifocal brain edema. Then we'll discuss this in the subject of brain infection and brain tumors in AIDS patients later on. And you remember that lymphoma in AIDS patients, as I have mentioned, may be surrounded by significant perifocal brain edema, and it may show heterogeneous post-contrast enhancement. Then we are in the differential diagnosis of tumors and some types of infections which affect these particular kind of a patient. But remember that lymphoma in an immune competent patient will show homogeneous enhancement, periventricular location, little brain edema, and little mass effect. And this is the T1 post-contrast MR images of the brain showing homogeneously enhanced periventricular lesions, diagnostic of lymphoma. And this is another case where you can see an intermediate signal lesion in the T1 and intermediate signal in the T2 surrounded by perifocal brain edema after contrast injection, and you see homogeneous enhancement of the lesions. And this is also a case of lymphoma showing low signal in the T1, high signal in the T2, some perifocal brain edema around the lesions, and homogeneous post-contrast enhancement. Then we have finished the first category of brain tumors showing homogeneous pattern of contrast enhancement in the supratentorial area, and we mentioned by far the most common lesion is the meningioma, and the second lesion is the hemangiopericytoma, and the third one is the lymphoma. And we have described in details the diagnostic imaging finding in each of these lesions. Then we came to the issue of heterogeneously enhanced lesions, and under this title we'll include most of the gliomas. Then you know that there is a new WHO classification of the brain tumors which has mentioned that the tumors should be classified into neuroepithelial lesions, nerve sheath tumors, meningeal tumors, metastasis lymphoma, intracranial cysts, and the germ cell tumors. And they classified the neuroepithelial tumors, which represent about 50% of all intracranial tumors, into the astrocytoma, the ependymoma, the oligodendroglioma, the choroid plexus papilloma, and the pineal body tumors. In order to not to disturb you and to have a simple classification of this or simple approach for these tumors, we have I will divide these tumors also according to the literature into what's known as the low-grade tumors and the high-grade tumors and a group of mixed lesions. Each of these categories may include 3 or more types of the tumors, and the literature says that low-grade lesions are seen in younger age, and plastic lesions are seen in the middle age, and the most aggressive glioblastoma multiforme is usually seen in elderly patients. But you know that this is not a rule, and you can see glioblastoma in the pediatric age group. Then we'll start this classification by the low-grade lesions and the high-grade lesions. We have 3 main types of tumors in this category, the low-grade tumors, including the pilocytic astrocytoma, the subependymal giant cell astrocytoma of tuberous sclerosis, and the pleomorphic xanthoastrocytoma, or referred to as by the BXA. Then we have three high-grade lesions: the diffuse astrocytoma, anaplastic astrocytoma, and the glioblastoma multiforme. Then we'll start first by the low-grade types, and the first one is the pilocytic astrocytoma, and this is a low-grade astrocytoma usually seen in the posterior fossa and is diagnosed by the presence of a cyst with an enhancing mural nodule. And you can see this is the CT scan without contrast injection, T1 weighted post-contrast injection MR image showing a cystic lesion in the cerebellum, in the posterior fossa, and this cystic lesion has an enhancing mural nodule. This is one of the common diagnoses in the pediatric age group and also in some adult patients, but this lesion is usually seen in the pediatric age group. A cystic lesion, low signal in the T1, high signal in the T2. After contrast injection, and you see the cystic lesion and an enhancing mural nodule, diagnostic of pilocytic astrocytoma. And this is an MRI, T1 weighted image, T2 weighted image, and T1 post contrast. The cystic component will show low signal in the T1, high signal in the T2, no post contrast enhancement. The solid component will show intermediate signal in the T1 and T2 weighted images with homogeneous post contrast enhancement. These are two different types of pilocytic astrocytoma: a cyst with an enhancing mural nodule, and you can see a septum or internal septations within the cyst, and this is acceptable, and the mural nodule may be located on the internal septum, and this is also acceptable. You can see here a cystic lesion with an enhancing mural nodule in the cerebellum, diagnostic of pilocytic astrocytoma. Then, what are the acceptable findings in pilocytic astrocytoma? These are: number one, enhancement of the cyst wall. And you see here a cystic lesion in the cerebellum, and this lesion is showing an enhancing mural nodule, and also the cyst wall may show contrast enhancement. This is acceptable. Number one, the injected contrast material may diffuse inside the cyst, producing a contrast fluid level, and this is also acceptable. The hemorrhage may occur inside the lesion, and it will also produce a blood fluid level, and this hemorrhage may mask the mural nodule itself. Also, the nodule may be small or large. It is acceptable. The cyst wall may show calcium, and this is also acceptable. Then, pilocytic astrocytoma may occur in the supratentorial area, but commonly it's in the posterior fossa. This is the lesion which is exactly locating in the hippocampal area, and this is an epileptic patient with a cystic lesion and enhancing mural nodule, and the cyst wall is also enhancing, located exactly in the region of the hippocampus, and is responsible for the patient symptoms. Then we came to the second type of low-grade tumors, which is the giant cell subependymal astrocytoma, and this represents about 0.3% of the tumors, and it occurs predominantly in patients with tuberous sclerosis. Then the tumor may develop from one of the tubers located in the ventricular wall, and the most common site of this particular tumor is the frontal horn of the left or the right lateral ventricle. And you see here, this is the CT before contrast injection and after contrast injection, and you see the tumor mass located exactly in the frontal horn of the right lateral ventricle near the foramen of Monro. And if you look carefully, you can see the calcified tubers in the wall of the ventricles, which represent the tubers of the tuberous sclerosis. After contrast injection, this tumor commonly shows homogeneous post-contrast enhancement. And here is the CT scan and MRI flare and MRI T1 post-contrast. You know that calcium in the wall of the ventricle is clearly identified in the CT scan, but is not accurately identified by MRI because of the low sensitivity of MR to the presence of calcium. And then you see the tumor, which may contain foci of calcification in the frontal horn of the right lateral ventricle. And this is the appearance of the tumor in the FLAIR image, and after contrast injection, you see homogeneous post-contrast enhancement. And this is the CT and MRI of the previous case with the giant cell subependymal astrocytoma in the right frontal horn of the ventricle, and you may appreciate the detection of calcium in the CT rather than in the MR image. A third or fourth case of subependymal giant cell astrocytoma in the frontal horn of the left lateral ventricle. You see calcific foci in the CT scan, intermediate signal in the T1 and T2 weighted images with homogeneous post-contrast enhancement. Then we came to the third one in this group, which is the pleomorphic xanthoastrocytoma, or the BXA, and this is the cyst with an enhancing mural nodule, but in the supratentorial area. This lesion is rare in the posterior fossa, and it occurs predominantly in the supratentorial area. And you see a very big cyst with an enhancing mural nodule against the surface of the brain. And this is an important issue in this particular tumor. The nodule should have a superficial location against the surface of the brain, whether this is the medial surface or the lateral surface of the brain. And this is the MRI, and you see the cystic lesion with an enhancing mural nodule, and this is the CT scan, and you see the cystic lesion with an enhancing mural nodule, and you know that the nodule should have a superficial location. Here is an example of BXA with the cyst and enhancing mural nodule in the T1 weighted image and in the T2 weighted image and T1 post contrast. The nodule should have a superficial location. Then we finished with the low-grade types: pilocytic astrocytoma, cyst with an enhancing mural nodule in the posterior fossa; subependymal giant cell astrocytoma, a homogeneously enhanced lesion in the frontal horn of the ventricle in a patient with tuberous sclerosis; and the BXA, which is a cyst with an enhancing mural nodule in the supratentorial area. And you should consider that the nodule has a superficial location on the surface of the brain. Then we came to the three types of the high-grade astrocytomas, which include diffuse, anaplastic, and the GBM. We start first by the diffuse astrocytoma, and these tumors represent about 10% of all primary intracranial tumors. It occurs in young adults up to the age of 45 and even more, and this tumor does not show any contrast enhancement. And you see in this CT scan a well-defined hypodense lesion. After injection of contrast media, you cannot see any pattern of enhancement. You see only the middle cerebral artery. Frequently, these tumors are mistaken for infarction, but you should know that infarction is not a specifying lesion. Infarction should have a vascular territory on the surface of the brain, and if you inject the contrast media, you will not see the vessel because the vessel is occluded, and you will see gyral pattern of enhancement, as you remember from the lecture of the cerebrovascular stroke. Then this is a tumor in the region of the insula, and the tumor is hypodense in the T1, low signal in the T1, hypodense in the CT image, low signal in the T1, high signal in the T2, and high signal in the FLAIR. And if you inject the contrast media, this tumor will not show any pattern of contrast enhancement. And this is another tumor, and you see a low signal in the T1, high signal in the T2, and this enhancement is because of the operation. You see this the flap, the operative flap, and you know that operation will disturb the blood-brain barrier. Then contrast media can reach the tumor, but if this tumor is imaged before operation, you should not see any pattern of enhancement like this one. And then this is T1 weighted image, T2 weighted image, and T1 post contrast, and you cannot see enhancement of the tumor. And this is what we call the diffuse astrocytoma. And this is another example where you can see a low signal lesion in the T1 weighted image, high signal in the T2 and the FLAIR, and after contrast injection you cannot see enhancement of the tumor itself, and you also appreciate the mass effect of the tumor on the ventricle, as you can see. Then, anaplastic astrocytoma is a tumor which is relatively more aggressive than the diffuse astrocytoma, and this tumor does not show hemorrhage or necrosis, which are commonly seen in the GBM, and it shows characteristically patchy enhancement, and you see some patches inside the tumor itself. It does not show heterogeneous or ring patterns of enhancement, and this is the classic appearance of this anaplastic astrocytoma. A low signal in the T1, high signal in the T2. After contrast injection, you see 2 or 3 foci of enhancement within the tumor tissue itself. And you can remember that there are no hemorrhage inside the tumor and no areas of breakdown or necrosis inside the tumor. And this is another example. In the T1 weighted image, you see this mass, and the T2 weighted image, and in the FLAIR, you see increased signal of the tumor in the T2 and in the FLAIR images. And after contrast injection, you see only patches of enhancement within the tumor tissue, and you know that most of the tumors will show diffusion free on the diffusion weighted images. The only exception for this tumor to be anaplastic astrocytoma is the presence of high signal patches within the tumor, which usually represent hemorrhage. And I have mentioned that anaplastic astrocytoma usually does not show internal hemorrhage. Another case of anaplastic astrocytoma, low signal in the T1, high signal in the FLAIR, and after contrast injection, and you can see some faint dots of enhancement, and this tumor is multicenteric, and you can see another part of the tumor on the opposite side showing the same characteristic pattern of enhancement. Then we came to the most aggressive tumor of the astrocytomas or the gliomas, which is the glioblastoma multiforme. And this glioblastoma multiforme represents about 15 to 20% of all intracranial tumors and about 50% of all gliomas. This tumor is of the malignant type, infiltrates the adjacent brain parenchyma, and no imaging technique can assess the true age of the tumor, meaning that at surgery, the tumor age may not be that seen on imaging. It will be much more larger than originally seen on imaging. And this is the CT scan before and after contrast injection, and you see a tumor which is marginally enhancing. And this is one of the criteria of glioblastoma multiforme is marginal enhancement, but the enhancing margin should be of non-uniform thickness in order to differentiate this from the abscess. And we have too many other ways to differentiate glioblastoma multiforme from an abscess. Glioblastoma multiforme, being an aggressive tumor, is surrounded by significant perifocal brain edema and exert a significant mass effect. And this is T2 and T1 post contrast. And you can see the enhancing margin of the tumor of non-uniform thickness with internal breakdown and also internal hemorrhagic foci, and this tumor is well known to contain hemorrhage and necrosis. This is the glioblastoma multiforme infiltrating the temporal lobe with marginal post-contrast enhancement of non-uniform thickness. And these are two different examples of glioblastoma multiforme showing marginal enhancement of non-uniform thickness. And you see the margin here is thin, the margin here is thick, and the surrounded by significant brain edema. And here you may consider this as heterogeneous enhancement or enhancing margin of non-uniform thickness, the same way for the diagnosis of glioblastoma multiforme. And this is a good example of glioblastoma multiforme in a patient with scissors. And you see the tumor is infiltrating in the region of the corpus, of the splenium of the corpus callosum, low signal in the T1, high signal in the T2 and the FLAIR, and the marginal post-contrast enhancement of non-uniform thickness. Another case of glioblastoma multiforme, and you can see the enhancement pattern of the of the tumor. Then we finished with the three types of high-grade gliomas, which are the diffuse astrocytoma showing no enhancement, anaplastic astrocytoma shows dots of internal enhancement with no evidence of breakdown or hemorrhage, the glioblastoma multiforme showing aggressive appearance with marginal non-uniform thickness, enhancing margin of non-uniform thickness, or heterogeneous pattern of contrast enhancement. Then we came to the final group, which is a mixed group of variable tumors. Some of them are of the low-grade type, some of them are of the high-grade type. This include the oligodendroglioma, the oligoastrocytoma, the gliomatosis cerebri, and multicenteric glioma, and finally the gliosarcoma. We start first by the oligodendroglioma, which is a low-grade type diagnosed by the presence of matrix calcification. And you know that calcium is better detected by CT rather than MRI. Then the tumor are easily diagnosed by the CT scan, and you can see a tumor contains the amount of calcium, variable amounts of calcium. Being a low-grade tumor, it is surrounded by little perifocal brain edema. And this is a good example of oligodendroglioma, which is the lesion inside the brain parenchyma showed matrix calcification with little, if any, perifocal brain edema surrounding the tumor. And you know that the detection of calcium is more easy by CT than by MRI. And this is a tumor which is located in the right frontal area showing foci of internal calcification. And this is the FLAIR image by MRI, which does not show the calcium but show the true extent of the tumor. And this is a good example to show you how calcium can be missed on MR images. And this is a extensively calcified oligodendroglioma by CT. And if you look to the MRI, and you can see only this area with dark signal representing matrix calcification compared to this huge area of calcium seen on the CT images. Then oligoastrocytoma is a mixture of tumors, oligodendroglioma and another form of astrocytomas previously mentioned. And according to the second part of the tumor, which is the astrocytoma, the tumor will appear. And if you see a tumor like this with calcium inside, you think of oligodendroglioma. But whenever you see that the tumor is sizable, is surrounded by evident perifocal brain edema, exerting a significant mass effect, and this is not the rule for oligodendroglioma. This oligodendroglioma should be mixed with another form of astrocytoma, maybe the diffuse type or the anaplastic type. Then there are significant perifocal brain edema and the significant mass effect. So if you see an oligodendroglioma because of the calcium, but this oligodendroglioma is surrounded by evident perifocal brain edema with significant mass effect, you think of this tumor which is known as oligoastrocytoma. Then the infiltrating glioma or the gliomatosis cerebri, and this is a tumor which is relatively rare, and it by its name infiltrates the brain parenchyma. This tumor, by definition, does not appear in the T1 weighted image and is not seen by the CT images. As you can see in this example, this is the T1 weighted image showing only compression of the occipital horn of the left lateral ventricle, and you cannot see any tumor tissue. But in the T2 weighted image, you can see some high signal lesion surrounding the occipital horn and also in the FLAIR. This tumor characteristically, if you inject contrast media, it will not enhance. And the gliomatosis cerebri, the difference between the gliomatosis cerebri and the diffuse astrocytoma. Diffuse astrocytoma is seen on the CT and the T1 weighted images MRI, but the infiltrating glioma will not appear on the T1 nor in the CT images. Both tumors will not enhance after injection of contrast media. Then the tumors in general, the diffuse type and the gliomatosis cerebri will show diffusion free on the diffusion weighted images. And this is an example of an infiltrating glioma or gliomatosis cerebri on the T2 weighted image. After contrast injection, you cannot see any pattern of enhancement, and this is the enhancing middle cerebral artery. Also on the CT scan, you cannot see the right lateral ventricle in this case, and you see a diffuse lesion here, or you can imagine the presence of a lesion that has compressed the ventricle. And in the T2 and in the FLAIR images, you see that the infiltrative nature of the tumor. After injection of contrast media, you cannot see evident enhancement apart from this very small focus. Also here you see the lesion. This lesion is apparent on the CT scan and also apparent on the T1 weighted image. After injection of contrast, it shows no enhancement, and this is also the T2 weighted image shows the multicentricity of the tumor being on the left and on the right side. And you should accept some of the variables. All what I have said is not a must, and you can accept some variables in the diagnosis of these tumors. And this is the diffusion weighted image showing free diffusion of the tumor. Then we came to the multicentric glioma, which means that the glioma with multiple foci, and frequently this appearance will be diagnosed as metastatic deposits. But in most of these cases, extensive metastatic workup will not show any evidence of primary malignancy. Then the diagnosis will be reached by the stereotactic biopsy. And here you can see an example of a male patient, 67 years old, presented by these two lesions in the MRI, one in the temporal lobe and one in the occipital lobe. And this appearance is usually diagnostic of metastasis, but an extensive metastatic workup showed no evidence of systemic malignancy, and the stereotactic biopsy confirmed that both lesions represent the multicentric glioma. And this is the case from the literature showing multiple enhancing lesions in the right cerebral hemisphere and diagnosed by biopsy as multicentric glioma. Also, this is a multicentric glioma, which is usually of the glioblastoma type, showing multiple foci of the lesions in both cerebral hemispheres, showing heterogeneous pattern of enhancement. Of course, in the differential diagnosis of this appearance, metastasis should be included. Also, lymphoma should be included in the differential diagnosis. Then the gliosarcoma is a rare malignant neoplasm of glial and mesenchymal elements. It has both components, and this tumor typically present in old age, the 6th and 7th decade. It has a poor prognosis, and one of the characters is the lesion invades the meninges and maybe the calvarium, and it shows, of course, local recurrence after excision, with extracranial metastases are commonly seen with this type of tumors. And gliosarcoma is a tumor which usually peripherally located, heterogeneously enhanced, similar to the glioblastoma multiforme. And the distinction between glioblastoma and the gliosarcoma is usually made by biopsy. You cannot reach the diagnosis of this tumor on imaging basis. This tumor has characteristic invasion of the adjacent meninges. But whenever you see a lesion like this, in the CT scan post-contrast showing marginal non-uniform enhancement, and also in the MRI post-contrast showing the same with extensive perifocal brain edema, you think of glioblastoma multiforme. And by biopsy, this lesion or after surgical removal may be confirmed as the gliosarcoma. Then we came to an important issue, which is the metastatic deposits. And the metastases usually show heterogeneous pattern of contrast enhancement. They are multiple, they are surrounded by extensive perifocal brain edema, and the patient is usually known to have some type of primary malignancy. Then this is a classic appearance of metastatic deposits: heterogeneous enhancement, significant perifocal brain edema, and significant mass effect. 85% of metastatic deposits occur in the supratentorial area, and the incidence of solitary metastatic deposit may reach up to 50% of the cases. And this is the metastatic uterine sarcoma. In the T1 weighted image, you see 2 lesions, and the T2 weighted image, you see the increased signal, and after contrast enhancement, then you see the heterogeneous pattern of enhancement. Multiple metastatic deposits in both cerebral hemispheres from renal cell carcinoma, showing high signal in the T2, homogeneous, almost homogeneous post-contrast enhancement, diffusion free on diffusion weighted images, and this is sagittal post-contrast enhancement. Because of the non-primary, it is easy to diagnose metastatic deposits. And here is T2 and T1 post-contrast, and you can see multiple enhancing lesions scattered throughout the cerebral parenchyma of both hemispheres, representing metastatic deposits. Metastasis can be diagnosed by multiplicity and the significant perifocal brain edema, even in the absence of a well-known primary malignancy. Then the solitary metastatic deposit should show heterogeneous pattern of enhancement and extensive perifocal brain edema. And by extensive, we mean that the edema around the lesion is about 3 times the size of the lesion itself. Then we consider it extensive perifocal brain edema. And if there is a known primary, the diagnosis is easy. If not, the diagnosis will be reached on either by metastatic workup or by biopsy. And this is T2. There is a lesion surrounded by evident perifocal brain edema. After contrast injection, the lesion showed almost homogeneous pattern of enhancement surrounded by extensive perifocal brain edema. And commonly, if you are looking for a primary lesion that can explain the presence of brain metastasis, this lesion will be present in the chest very commonly. Then you see this is the case of a male 60 years old patient presented by this lesion in the brain parenchyma, showing a marginal enhancement of non-uniform thickness surrounded by extensive perifocal brain edema, suggestive of glioblastoma multiforme or a metastatic deposit. Then if you look in the chest of the patient, then you see this classic appearance of a bronchogenic carcinoma. We'll discuss this in the literature, in the lectures of the chest and the chest imaging. Then you can see these are the abbreviations for common lesions producing metastasis in the brain. BEB means the bronchogenic carcinoma and the breast cancer, MR, melanoma and renal cell carcinoma, CT, the choriocarcinoma and the thyroid carcinoma. Then you look, I'm sorry, you look at this case of metastatic bronchogenic carcinoma. In the T1 weighted image, you see the lesion with extensive perifocal brain edema. In the FLAIR image, in the T2 weighted image, and after contrast injection, then you can see a mass, and this mass is surrounded by extensive perifocal brain edema. Brain deposits can be cystic like this, and you see this is a cystic lesion with an enhancing neuronodule and marginal enhancement. But being the patient is known to have a breast cancer, then you know that this is the cystic metastatic deposits. Also in this case of an intraocular melanoma, and you see multiple widespread metastatic deposits throughout the brain parenchyma. Even though if you don't know that the patient had a specific primary malignancy, you can easily diagnose this as metastasis. And you see a lesion in the posterior fossa, multiple lesions in both cerebral hemispheres, regardless the enhancement pattern, ring or homogeneous or heterogeneous, but multiple lesions surrounded by extensive perifocal brain edema are diagnostic or highly suggestive of metastatic deposits, and the metastatic workup may show the primary malignancy, especially in the chest, and if not, the biopsy will confirm the diagnosis. And in conclusion, we came to the fact that we can reach the diagnosis of brain tumors in the supratentorial area based on the enhancing pattern of these tumors. And we start by the homogeneously enhanced lesions, and on top, by far on top, the most common homogeneously enhanced lesion intracranial is the meningioma, provided that the tumor has a dural base. And the second one is the hemangiopericytoma, which is a sizable tumor seen in males, more common than females, and it may erode the calvarium in contradistinction to the meningioma, which usually produce hyperostosis and thickening of the calvarium. Then the third one is lymphoma, and lymphoma is the homogeneously enhanced lesion, periventricular in location, no dural base, can cross the midline surrounded by little perifocal brain edema. Then this is also an homogeneously enhanced lesion, which is the giant cell subependymal astrocytoma seen in patients with tuberous sclerosis. The tumor has a characteristic location and the characteristic appearance, and if you have the CT scan, you may have the chance to see the calcified subependymal nodules. The heterogeneously enhanced lesions are, number one, the glioblastoma multiforme because of the internal hemorrhage and necrosis. And then you may consider anaplastic astrocytoma because of the patches, internal patches of enhancement, as a heterogeneously enhancing lesion. Marginally enhancing brain tumor is only the glioblastoma multiforme, considering that the enhancing margin is of non-uniform thickness. And you can compare this enhancing margin to the margin of an abscess. And the margin of an abscess is relatively thin and is of regular thickness all around. Then an enhancing mural nodule is seen in pilocytic astrocytoma, which is a cystic tumor with an enhancing mural nodule commonly located in the posterior fossa, and also seen in the BXA or the pleomorphic xanthoastrocytoma, which is a cyst commonly located in the supratentorial area, and you consider that the enhancing mural nodule should have a superficial location. Then any pattern of enhancement is seen with metastasis, and metastases are diagnosed by multiplicity, by the extensive perifocal brain edema, and by the presence of primary malignancy to help in the diagnosis. No enhancement is seen in the diffuse astrocytoma, which is the tumor seen in the T1 weighted image, low signal in the T1, hypodense in the CT, high signal in the MRI T2 and the FLAIR, and if you inject contrast, the tumor will not enhance. Also, the infiltrating glioma or the gliomatosis cerebri, which is not seen in the T1 nor in the CT, and it will show no contrast enhancement. Intracranial cysts will be discussed in a separate lecture, and most of these cysts do not show any pattern of contrast enhancement. And I thank you very much.